The following audio-supported podcast is intended for informational and educational purposes only and is not intended as medical advice. Please speak to a healthcare professional before making any treatment decisions. The guests on today's show were paid to participate in this podcast.
Hey Thal Pals, it's your friend and fellow patient advocate, NinaMaria. I'm here along with my co-host, Dr. Kevin Kuo, and you're listening to Thal Pals, the Alpha Beta Revolution. Today we're discussing results from a global health literacy survey in thalassemia. It was conducted by the Thalassemia Advocacy Advisory Council, which is a group of patient advocates and healthcare professionals with the goal of addressing the unmet needs in the Thal community. With us today, we have two thalassemia legends and members of the council, Dr. Sujit, Sheth, and Dr. Nica Cappellini. And I have to say, it is an honor to be seated down with them. We have such a treat for you guys. So let's get started and have these two introduce themselves and talk about their connection to thalassemia.
I'm Nica Cappellini. I'm a professor of internal medicine at the University of Milan. And I started to work on thalassemia since the beginning of my career when I was a resident, becoming interested on an hereditary anemia. And I did it for more than 55 years already. I'm now retired, but I'm still involved with the community of patients, physicians, and I still get excited whenever I can give my expertise or share my expertise with a colleague and a patient, of course. And I get involved in this initiative, and I'm so pleased to be there and to be involved because I had the opportunity to understand and to discuss the unmet need with colleagues and patients, caregivers, member of representative of association. So it was an experience that enriched me a lot.
NinaMaria and Kevin, thank you for having me here. I want to set the record straight. There's only one legend here, and that is Nica. There is. It's the honest truth. But it is my privilege to count Kevin and Nica as colleagues, and to work together with them to further the optimization of care for thalassemia. I'm a pediatrician. I'm a pediatric hematologist. My entire career has focused on disorders of red blood cells, and I think the red blood cell is the most important cell in the entire body. And I tell everybody, the cardiologist says, no, the heart is more important. I said, the heart is just a pump. And what does it do? It pushes the red cells around, because the red cells are the key to everything.
Absolutely.
So I think that it's been a privilege to be in this field, and I feel lucky and honored to be considered part of the family for most of my thalassemia patients.
We're lucky to have both of you guys.
Yes, and I would say the pleasure and the honor is ours, Professor Cappellini and Professor Sheth. Thank you.
Agios is a biopharmaceutical company that's fueled by connections with patient communities, healthcare professionals, partners, and each other. Building on these connections and the company's unmatched leadership in PK activation, Agios is pioneering therapies for rare blood disorders, including PK deficiency, thalassemia, and sickle cell disease. To learn more about thalassemia, visit rethinkthalassemia.com. To join the conversation with other patient allies, follow us on Instagram at Ally Voices Rising. That's Ally, A-L-L-Y, Voices Rising.
So to kick us off with the first question, maybe we'll start with you, Professor Cappellini, and then we'll come to you, Dr. Sheth. Is that you both led very busy lives. I mean, in fact, we were just talking before we started the podcast that you're now busier than ever, Dr. Cappellini. So being so busy, especially advocating for people with thalassemia, advocating for the community, what made you decide to join the Thalassemia Advocacy Council?
Yeah, actually, I believe that we never end to learn and to improve treatment for patients. So joining this advocacy group was extremely important for me to understand in real life, dealing with patients and caregivers, nurses, what are the missing need that we need to cover. So I was used in the past, to think myself or to discuss for how to improve treatment, for novel treatment, but dealing directly with patients, that was a great experience. And that's, I'm so glad that I was invited to be part of that. And this, maybe we can discuss later on the outcome of this survey, but that's actually teaching a lot for improving care of these patients.
I'm going to say it was very easy. Two things. First, when I was invited to be on this and I saw the list of people that were going to be on this, I was like, no brainer, I have to be on this advocacy council. And so it was easy. To be with all of you guys, and it's truly an honor. And it is so important because we have come a long way in managing thalassemia, but we have a long way to go still. Okay? I was just talking with Kevin before. We have not optimized treatment. We have come to the point where we can say, okay, this is adequate. This is okay. We can get you by with this, and this. But it's not optimized. And so I think we still have a ways to go. There's still unmet needs that we have not addressed. And so hearing the patient voice, hearing the provider side of things, and mixing it up with all of the other stakeholders, the parents, advocacy groups, everybody, that made a huge difference. Yeah. So it really is an amazing group to work with.
I think that's a great point that you make. I think we have come so far for patients with Thal, and it's incredible, and it feels like each step we take, it leads to more doors. Each door we open leads to more.
Absolutely.
It's really great that we are elevating the quality of life, but like you said, we're not to the optimal spot yet, and I think that's a great highlight.
We want you to be normal. We want everybody to be normal, not adequate. Not okay. This is the bare minimum, and if we're achieving the bare minimum, we're good. No, we have to now push the envelope further and get you to as normal as possible.
And that cannot be an initiative of physician, but should be an initiative, a joint initiative between patients and the physician. That is the way to really go farther and try to get the best.
Absolutely. So this project was all about health literacy. From your perspective, why is health literacy in thalassemia patients so important? Dr. Sheth, we'll start with you.
It's absolutely critical. Patients need to keep their doctors on their toes. Otherwise, doctors get complacent, right? Doctors get complacent because, okay, we know this much about thalassemia, and that's fine, and that's adequate. It's not. And if patients don't advocate for themselves, we get complacent.
Yeah.
And so we need to be pushed. We need to be on the cutting edge. We need to be on our toes, always alert, always keeping track of the newest developments and not getting complacent at all. So it's that partnership needs to work.
Dr. Cappellini, what's your point of view on health literacy?
Well, I totally agree with Dr. Sheth's comment. I mean, we need to have a joint adventure and to try to, let's say, play together. I want to use the terms play because actually it's the way to improve and to proceed in terms of as it was said, try in terms of trying to reach a normal life, a normal way to live, although the disease is there, but we can really fight against.
So, Dr. Sheth, I want to ask you a question, and I want to preface it by sort of describing the survey that was done as part of the project. So the survey was on people with thalassemia all over the globe. And one of the key insights that was found in the survey was that although patients felt confident with the knowledge, there were clear gaps in the knowledge, and specifically in the relationship between hemoglobin level and the symptoms, and also the need for monitoring, not just for those with transfusion-dependent thalassemia, but also for those with non-transfusion-dependent thalassemia. So my question to you is, why is there such a paradox?
That's an excellent question. The bigger problem is not the transfusion-dependent patients, but the non-transfusion-dependent patients. They have always been made to feel like they have milder disease. In my opinion, non-transfused thalassemia patients have a more severe disease, because in 2025, we can optimize transfusions, we can optimize chelation therapy, and they can live near normal lives, except for the burden of coming to the hospital and all of those things, which is a significant burden, don't get me wrong, but it's not the inexorable progression of the underlying thalassemia that NTD patients have. And we are not doing the best we can by these individuals. Mm-hmm. You know, having a hemoglobin level of 8.5, not requiring transfusions, does not mean that your quality of life is good. It does not mean that you're not having complications related to your underlying thalassemia. So we have to push that envelope. Mm-hmm. And it was actually a little bit surprising to me, but not totally surprising to me, that the survey found that even though patients expressed confidence in their knowledge of their disease, mm-hmm. it was not actually that true. I mean, that they didn't really know as much as they thought they knew. Mm-hmm. And that comes back to us. And that is our job to make sure that patients are well informed. I don't like to use the word educated, but well informed and stimulated to learn more about their condition than they otherwise would. It is on us. So it's a joint effort. All of us have to be part of this, which is why this group, putting all of these stakeholders together, was absolutely ingenious.
Mm-hmm. Yeah.
I remember Professor Cappellini, you always tell that story.
You can say Nica.
You always be my mentor.
I don't feel to. Okay.
It's difficult.
Okay.
But you always told us that story, the story about how when you were younger, you used to tell your patients that you're lucky to have non-transfusion dependent thalassemias, and tell us that story again.
Yes, actually, what Sujit said is the truth. Today, we realized during the last, I should say 10, 15, but even not 15, 10 years, that the non-transfusion dependent thalassemia patients are those having the worst clinical course, because the anemia, the chronic anemia, is responsible of so many morbidities. And going back to my experience, I really was living the experience day by day, because at that time, having transfusion-dependent patients, and those at that time we said thalassemia intermedia, who were able to maintain a level of hemoglobin 8.5, sometimes 9, we thought was a fortune. And I used to say, you're lucky, you're not transfused, you're not accumulating iron, you can live with this hemoglobin level. Now when I see some, unfortunately, already passed away, but when I see the non-transfusion-dependent thalassemia patients who are now 40, 45s, and they have so many morbidities due to extramedullary hematopoiesis massive, to chronic anemia, which per se is responsible of organ damage. But also we realize that these patients, even if they are not transfused, they accumulate iron in the liver, mainly in the liver, because iron is absorbed. So unfortunately, we made the story of non-transfusion dependent patients seeing the complication they have. And today is absolutely important to make anyone knowledgeable of that, physician, patients, but also, let me say, the authorities, because we need to do something for these patients. We need to give them the opportunity to be properly treated.
And I'm just going to add that when Nica was initially talking to her patients and saying how lucky they were, she was probably right. Because in the 80s and 90s, you were lucky if you didn't need to be regularly transfused, because you had the risk of getting HIV, you had all of these other risks related to your transfusions, and we didn't have optimal ion chelation either.
Exactly.
So at that time, it was probably appropriate to say you were lucky not to need regular transfusion.
Yeah.
But we've come a long way. And now we know so much more about the optimal hemoglobin levels,
Yes.
about the risk of complications if your levels are lower than that. So we have to change the paradigm.
Yeah.
We have to push the envelope and ask these patients to be more proactive about these things. And you said the authorities, absolutely, the authorities need to be involved
Yeah.
in this as well.
Yeah.
But also, from the educational or informational standpoint, parents of
Yeah.
patients who are making decisions, who are saying, no, I don't want my child to be transfused. Okay? That's,
Yeah.
in this day and age, we have to work together with them and make them aware of what not transfusing them would result in the long term.
Yeah.
And convince them that we can manage all the complications around transfusion. The blood supply in the developed world is safe.
Yeah.
We have oral ion chelators. We can manage this quite well.
Yeah.
And prevent all those complications, the bone changes, all of those things that happen in the non-transfusion dependent patients.
I want to make a point, add a point if I can. What we didn't know at that time, I didn't know, but in general was not known, is the role of ineffective erythropoiesis. Because the chronic anemia these patients maintain is due to ineffective hemolysis, but mainly to ineffective erythropoiesis. And I always keep in mind something that Professor Stamatoyiannopoulos told me once. He said, listen, Nica, ineffective erythropoiesis per se is a disease because it's causing a lot of damage. If you have an iron deficient patient with the same level of hemoglobin, but is not going through all these complications because there is no or at least mild ineffective erythropoiesis. So we have to keep in mind that, and that's something I realize after some times, that the main driver of the let's say morbidities, complication, whatever you want to call, in thalassemia is ineffective erythropoiesis.
For the listeners out there, ineffective erythropoiesis essentially are these baby red cells that are trying to grow up, but they couldn't grow up.
Yes.
And instead of growing up and being able to exit the bone marrow and to serve its purpose, circulating in the body, they die prematurely inside the bone marrow. and that can cause a lot of toxicities that we didn't know before, but now is quite well known.
Yeah.
You have an alternative career as a talk show host. That was brilliant. That was absolutely brilliant.
I say it all the time.
Terrific.
He explains things so well. Like, he makes them
absolutely.
so digestible and understandable.
Yeah.
We appreciate that. But to your guys' point, I think leaving well enough is not good enough. We need to keep pushing, and we do have the resources. Bouncing back to your point on the responsibility of physicians, the survey noted that most patients did have confidence and trust in their physicians for information and for their health management, yet we saw the gaps in the patient's knowledge. So Dr. Cappellini, what do you think we can do to better support physicians to make sure that they are keeping up with the latest data and sharing that with their patients?
Yeah, this is a very good question, and keep me thinking what is better to do. Simply speaking, what is necessary is to improve the awareness of physicians. Unfortunately, often physicians believe to know everything, so it's not easy to work on this field. But I think that is our duty. We have to do that, and through also this advocacy group, I think we can work together and doing education, providing education tool to physicians, to nurses, to any kind of caregivers, and to let them know that the progression of knowledges in the field are extremely important to properly drive the treatment, even the standard of care. So even that is not always well implemented. So I think we have to do, let me use the word education, although we don't want to educate anyone, but we want to share experience on that.
Yeah.
I will just add to that and say that what was particularly concerning to me was that this sample of patients who responded to the survey would actually have been selected out as being more aware than the average thalassemia patient.
Yeah.
So this throws it back on us even more, on the providers and physicians. If 3/4 or 2/3 of the patients relied on their physicians, and these patients were the more informed patients, and they still didn't know what the threshold for complications, hemoglobin threshold for complications was, that is on us, and we really need to do better. Yeah. And as Nica said, we have to move away from the idea that the physician is like a godly figure and knows everything, and actually engage more directly with patients and families.
Yes.
And maybe speak the Kevin language, the baby cells and all these kinds of things, and really get them all up to speed with what is actually going on. So it is more on us right now. If we are the reliable source of information, and yet they are not answering the survey appropriately, then it really is on us.
Yeah, but I think that from both sides, physician and patients, the one who are most knowledgeable, they really should or could be ambassador and bring their experience and knowledges among the patient's community.
I will just add one. We have to be very careful, because in 2025, with everything on the internet and everything that is on social media, we have to be careful that the information that's out there is really vetted. It's actually correct and true information. Because there's so much misinformation out there, and so many patients patients will come and see me, I'm part of this Facebook group, and this is what they were saying, and it's like, I'm glad you came to me before you believed it and asked me this question.
Yeah, that's a good point of the dual sides of that, having patients and physicians working together. Because there really is something special about a patient-to-patient relationship, and being able to relate someone on a level you never have before, and being able to work together on, I felt that way too, or, what do you do? It really is a beautiful relationship. And also, like you said, we need the physicians to back us up and be like, this is good information, this is accurate, but this, I can explain why it might not work for you. So it really is that pair, that dynamic duo to really boost knowledge and push forward.
Yes.
And what you just mentioned right now actually brings to another survey result that we all looked at, and that's the patients really want to learn more about thalassemia, and yet, as you have mentioned, Dr. Sheth, is that they're looking at a variety of sources. They're looking at their peers, they're looking at the physicians, but they're also looking at social media and searching on the internet. From both of your perspective, maybe we'll start with you first, Dr. Sheth, is how do we prevent that echo chamber from occurring? How can we bring accurate information to our patients?
So what we need to do is to figure out how physicians can make their days 36 hours long. Because sometimes we sit down with the patient and have a conversation, and sometimes it can go on for 30 minutes, 45 minutes, and then I'm thinking, I have 4 more patients to see in the next hour, and if we have this conversation, it's very hard for me to cut a conversation short. That's not fair to the patient at all. So, one of the things that we have to figure out is how can we make our time better utilized as well as better sort of spread out amongst our patients. Because we need to spend that time. There's no substitute for that. I can't hand you a sheet of paper and say, read this, or a website and say, go to this website. It has to be, because you trust me, I'm going to talk to you, I'm going to spend the time with you, and that's going to be the most powerful way for you to assimilate that information, as opposed to going to some random website, and not random, but they're good websites, not to say random. They're good websites, but to read through them, sometimes it's not easy.
No,
It's better to hear it and be
Yeah.
able to ask your questions in real time and get answers in real time as well.
Absolutely.
Yeah, this brings me to a comment. Dr. Sheth is right. We cannot have the day longer than 24 hours. And I still have, although I'm retired, my phone with all the number of the patient and so on. But this brings me to a consideration which I believe has to be planned for the future, which is not yet the case, which is to have a multidisciplinary is not right. Let's say different people involved in the group to take care of the patient. Today we talk of a multidisciplinary team where, of course, the hematologist, internist, whatever you want, is really in charge to coordinate everything. But to have more than one person to rely on, to discuss on, actually to discuss with, is making the life easier for everyone. And I think that has to become more and more important. And I realize myself that the figure of a psychologist in the group is extremely important.
Absolutely.
I would say psychologist, it doesn't have to be a psychologist, a social worker
Yeah, exactly.
who has the training to actually delve into all of the sort of other dynamics that are going on, right, is a great resource. to put into this mix. Sometimes, psychologists, patients are a little like, why am I seeing a psychologist?
No, you're
I don't need a
right.
psychologist. I'm not. I don't have a mental illness. But social work is a little bit less sort of obtrusive to
someone
them.
who take care of
it's more like,
problem,
I'm going to take care of you. I'll deal with your this
life.
problem, your that problem. At the same time, I can give you quote unquote therapy, as in, understand your trials and tribulations and try and help you with it.
That's such a great point, because I feel like, as a patient, time with your physician is so precious, and it's like, we know you guys are busy people and you have lots of patients, just like us, and so it's like we have to try to like optimize that, whatever it might be, 15 minutes of time or whatever it is. And like, I like to like make I'm a list person, so I'll like list what I want to talk about and then like prioritize. I'm like, okay, I at least need to talk about, maybe there's 5 things on my list, but we're only going to get to 2, so like which 2 are the most important, right? So
but you can do that, but most of the patients can do that.
Right. So I think that social worker and other members of that team would serve to fill those other aspects that maybe some of it is mental. I'm worried about this thing, but really we need to talk about these numbers first, and then the worries. And so
sometimes the patient will say, I'm really concerned because I'm changing jobs and my insurance will change all this. More for us in the US than in Europe. But those kinds of things, social worker can absolutely sort out just fine. And I don't need to because I'm a little bit removed from that anyway, right? Because I don't deal with those things as much or in as much detail. And so in those, it's like, distributing the sort of complexity of care amongst different providers.
Right.
And that makes a huge difference too.
Absolutely. Because there's so many important parts that come with care and quality of life.
Yes.
That's a great point. I am curious, and you might have alluded to it earlier, but was there anything about this survey that surprised you guys? We'll start with Dr. Cappellini.
Well, in some, was not really surprising, was actually the poor consideration that anemia per se can cause long-term complication. I mean, patients, particularly those who are transfusion dependent, they know that anemia should be treated by transfusion, but it wasn't clear for quite a large proportion of patients that having an hemoglobin level below, let's say 9, and I don't want to say 10, which can be too much, but below 9 could be responsible of long-term complication, or sometimes even not too long-term. So that was a bit surprising, but it's back to what we said before. Particularly non-transfusion dependent patients being anemic was normal, And what is fun is not the right word, but what is very interesting is dealing now with some non-transfusion dependent patients who have been enrolled in clinical trial. When they experience the increase of hemoglobin, they realize how life can be different. And I always mention of 2 young, beautiful ladies with NTDT being involved in one trial, double-blind trial. I was so worried because I said, oh my God, okay. And after 2 injections, I came through the patient's service, and they called me, oh, Professor, you are blind. We are not blind. We know that we are taking the drug, because they were feeling so better. And I was surprised. And they say, oh, we never realized how better we can feel with 1 or 2 grams of hemoglobin more, you know. So that was a bit surprising me that there wasn't a real knowledge about the level of hemoglobin.
Yeah, I can't imagine what that must have felt like for the first time to feel a higher level as someone who's transfusion dependent my whole life. And I was telling Kevin this earlier today. I cannot fathom living at a baseline of 8,
Of course.
7, even 9.
Of course.
And so it just is like mind-blowing to me what that must feel like to, because I feel the difference, but you know, I get to maintain that.
You know that you are.
Yeah. Dr. Sheth.
I was actually surprised, but also not surprised that so many of the non-transfusion dependent patients didn't realize how much monitoring is really, really important for them. And you know, because I think in the community as well as in the medical world, we have kind of peripheralized them. We've focused so much on the transfusion-dependent patients and all the complications that they have, that we have not paid enough attention. And this is on us as well. Again, we've not paid enough attention to the non-transfusion-dependent patients, and that's what we are now seeing with all of the studies that Nica and Ali and Khalid have done, that have made it so clear that it is not a benign condition by any stretch to be non-transfusion dependent. It is really, as I said before, I think it's a more severe condition than transfusion dependency. And I just want to add one more thing, just a story as well, as Nica mentioned, is one of my patients, again, novel therapy, and I'm seeing her 6 months after, and I say, you look different somehow. And she looks at me and she says, yeah, I'm not wearing all that makeup anymore because I don't need it. I used to put all this stuff on and all this stuff, and now I feel great looking the way I do because I don't look as pale, I don't look as jaundiced. This is what we really need to push the envelope. We need to make them feel better and more normal. You know, she literally was caking her face with makeup because she didn't want anybody to see her in that condition. Now she's great. I'm doing well. Big difference.
It's remarkable.
I know. Yeah, that comment in itself is better than any hemoglobin measurement or any patient-reported outcomes or any other markers that we have to judge success. So last question for both of you. Both of you have had very unique experience of working with a variety of people, including the patients, the caregivers, the advocacy group, advocates, as well as caregivers as well. And so from your perspective, maybe we'll start with you first, Dr. Cappellini, is that what have you learned from collaborating with such a diverse group of people? But in particular, how do we bridge the gap in communication? Like, meaning, how do we help each other to speak the same language?
Well, I think that it came spontaneously as a flow. I don't know how to say. I mean, although the language could have been different, I didn't felt any real problem on listening and communicating with the other members. And that was, I think, spontaneous and really very effective, because for me was in many years really the first time to sit around a table, although was virtual in many occasions, but with different, let's say, figures all together. And that was extremely, let's say, important, and also after any meeting we had, I was trying to figure out positive, positive outcome, which I try to implement in my daily life in the field.
I'm going to say that I think that the most valuable experiences that I have had have been when we've had those patient family days that the advocacy organizations organize. So the Thalassemia Foundation in the US, which has been tremendous in facilitating this interaction. Because, not all patients have access to expert thalassemia care, right? They have thalassemia care, but it's not always optimal and expert. And so when they have these kinds of days where patients and families can interact with actually people who do this for most of their clinical time is spent taking care of thalassemia patients, and they have the experience and they're at the cutting edge, they get the opportunity to have more of these discussions. They get the opportunity to ask questions. And I think that is tremendous. And this year, TIFF, the Thalassemia International Federation, and the Thalassemia Foundation did it together in the US, right? And I think that was also fantastic. And I had patients who reported, unfortunately I was not able to go, but they reported back to me, this was a great meeting.
Yeah.
So these are the kinds of things I think that we really need to encourage. Yeah. And we need to have more of this kind of interaction so that patients get to talk to people that they can hear and believe and feel confident, okay, I'm on the right track, or no, I need to go back and advocate for myself to my physician that I'm not being optimally managed and I need this, that, and the other.
Absolutely.
So I think this needs to happen more.
Absolutely.
Well, I think that's a wrap. Thank you very much to my colleagues as well as my mentor for being here with us today. Thank you for lending your expertise and your passion in especially addressing the unmet needs in thalassemia. And so don't forget to like and subscribe. And we'll see you next time at the Thal Pals, the Alpha Beta Revolution.